Right, in theory. It's going live. Okay, ready when you are.
Thank you very much. Good evening, everybody. I'm Councillor Julian Bell. I'm the Chair of the Health and Wellbeing Board and want to welcome you to our Health and Wellbeing Board this evening. We have got a packed agenda, a lot to get through, so I'm going to move swiftly on and ask for apologies for absence. Do you know, Keith, what apologies we've had? Have you got a list of apologies, Keith? Can you hear me?
I can. I'm sorry about that. Yes, we've had no apologies. Okay. But I have to say that Councillor Sabiers isn't with us.
Okay, yeah, he may join us. Okay. And I know for those who don't know, Councillor Sabiers has taken over Councillor Mason's cabinet role as the portfolio holder for housing, planning and transformation. So that's why Councillor Sabiers is now
Chair, can we just stop a minute?
Cabinet committee.
Sorry.
Yeah.
I'm trying to wait for this.
It's saying I'm live on YouTube on mine, so I think we're working and up and running.
I'm trying to stop it from playing.
What, when we get those little interjections? Right.
Hopefully that sorted it out.
Okay. Thank you very much.
Sorry about that.
No, that's all right. Okay. So urgent matters. There are none. Declarations of interest. Are there any? Matters to be considered in private. I'm not aware of any. Can we agree the minutes of our meeting that was held on the 24th of September? Is that agreed?
Agreed.
Thank you very much.
Chair, can I just have one correction? Just the title of the trust on page 1 is London Northwest University Healthcare NHS Trust. It's not Northwest London, it's London Northwest.
Thank you. These things matter. So yeah. Thank you. Fine. Now you will note, if you got to the end of those minutes, that we actually said that the first item on the agenda tonight would be Gossad's presentation, and I believe that we are ready to take that item. Is that right?
We are, Chair. I just mentioned the fact that we did get a request, which I forwarded on to you, from Roy Willis, that he...
Well, I'm hoping if we can crack on, that we'll be free to do the questions before 7, before Roy has to leave us.
Okay,
that's fine. I think I need to honour that commitment to take this one first, before we then go to the questions.
That's fine.
Okay, so hopefully if we're expeditious in the way that we do this, we can get it all, these two items in before 7 o'clock. So
Chair, it's Anna. I can start the slides if you'd like.
Yes, please, if you have them. Do we have somebody from GoSAD as well?
Yes.
Yeah, Shamaka is yeah.
Hi, Shamaka.
Can you all hear me?
We can. You're a little bit faint. If you can try and increase your volume.
Yeah, let me do that. Can you hear me now?
Yeah.
Is it better?
Yeah. Okay. And apologies that we didn't get to hear you last time.
Sorry?
Apologies that we didn't get to hear you last time and we had all those technical problems.
No, it's okay. Sometimes they say patience is a good thing, it's a virtue.
Indeed.
Yeah.
Okay, over to you.
Yeah, thanks a lot. And thanks, Keith and Anna, for helping me with the slides.
Okay.
Yeah, so basically, the impact of COVID-19 on Ealing's BME communities. Just a bit of background information. GOSAD wanted to do the survey by itself because we see roughly up to 450 users a year. And we work with all different sections of the community. But then because we're working with other organizations, I decided that maybe it's a good thing to involve them. So it's actually, the organizations are 6 organizations all together with GOSAD, and I'll come to explain all the organizations. So far, over 25 of our beneficiaries, basically people that are known to these organizations from the BME community, have unfortunately succumbed to COVID-19. There's a lot who in hospital, who are actually also getting support through their families by these organizations. So COVID-19 has exposed and brought to the fore deep-seated inequalities that continue to disproportionately affect the BME communities. Now, these groups, in combination, they've existed in Ealing for over 100 years. So that's a lot of experience and a lot of intervention, basically supporting a lot of people who have a lot of needs, and most of them are from marginalized communities. Now, we also found that apart from the users going through a lot of difficulties, also these organizations have been going through a lot of difficulties. And this is something sometimes it doesn't come to the fore, nobody discusses about these issues. And if you can go to the next slide, please. So the participating organizations are Golden Opportunity Skills and Development, which is GOSAD, United Anglo-Caribbean Society, which was set up in the early 70s. Then you have the Ealing Somali Welfare and Culture Association. This organization was recognized by Ealing Council for settling the early refugees from Somalia who were coming to settle in West London in the early 90s. And then you have the Tamil Community Center, which actually support a lot of the Tamil community in Ealing. And then you got the CAM Women and Girls Development Association, again working with a lot of mostly marginalized communities from West Africa. And then you got Horn of Africa Disability and Elderly Association, which again has been operating in Ealing from 2002. Next slide. Now, I'm sure most of you have been able to have a chance to go through the report. So what I've done, I've just picked a few things. So basically, we decided to look at some of the experiences this organization had in terms of the types of people that they support. We're actually surprised to find that there's a lot of similar examples and similar kind of interventions and support that's been provided to the different communities. Now, these are just 2 examples, as I said, but there's many, many examples. Now, this example is a child who's of BME origin, found to have special needs. So what happened is the mother was asked to come to school and sign some documents, which she didn't know about, but she was actually, through an interpreter, she was told that her child will be provided support. So this is a child who was at reception at the time. Now, what happened is the mother works over the weekend as a carer, and she was given the last document to sign. She wasn't given the full education, health, and care plan to sign, but just the last document. So she did that, but she was able to keep it in her handbag. And when she went to work, one of our colleagues who also come from the same community as her. She was actually able to give her the letter to say, please, can you read for me? I need to read to understand it. And, on top of the document, it says special needs or special education, something like that. So this lady who was helping her, also her English was not very good, but she just retorted by saying, oh, has your son got disabilities? And the mother was a bit surprised. Said, no, my child hasn't got any kind of disability. And she said, well, you signed a document that talks about special education and disability. So what the mother did was she got so confused that she could not work. So she had to call the employer and say, I need to leave work. And during the weekend, she contacted this organization that is part of this group to say, I need some support. I don't know what's happening with my child. Now, what happened is this organization was able to support the mother, going to the school. The school actually apologized for, what has happened. And the mother was adamant that my child has got no problem. So because the mother was so upset, she decided to move her child to another school. Now, this happened within the same term. So when the child was moved to another school, the child actually excelled in that school. And within the same term, the child was found to be very competent in all the different areas. So this is just an example of, we talk a lot about root causes of inequalities, and we've done, for example, GOSA has done a lot of projects on youth crime and knife crime, and we've actually identified, and also we did a project on supporting young people who are not in employment, education, or training, but who've got additional special needs. We found most of them when they were, put as special needs through schools, there's not a lot of support, and actually that actually affected their education. They eventually probably dropped out, and then of course it's easy for them to be vulnerable and join gangs and things like that. So we see this kind of cases as an example of how the systems sometimes can work against families if there's no proper support. The other example is another organization attended an event, and this event was they were talking about FGM, which is, if most of you don't know what it means, it's female genital mutilation. Now, when they attended the event, the event had a panel of experts, and the panel of experts, there was no one actually from any practicing communities. And in that event, actually, there was a lot of kind of stereotypical, information, and also kind of what somebody actually mentioned about a family that had moved to Africa, and that there was suspicion that they did that because they wanted FGM done on the daughters. So this person attending this event was able to challenge, those people on the panel, and actually it ended up causing a lot of discussion within the group. So this one example is about, the beneficiaries this organization see, and the other one is about what organizations, for example, who have good expertise and knowledge, but unfortunately they're not involved in kind of discussion around, for example, areas of FGM and other areas. Thank you, Anna. Next slide, please. Now, during COVID-19, what happened is, with Ealing together, which I think is something I need to say here, it was probably the first time myself I've seen how the council has worked really well with the sector. And it's a prime example of how things can happen in terms of collaborative working. And also, I think the council has been able to see the effects and the power of some of the smaller organizations, maybe in the borough. Now, during the pandemic, especially the first lockdown, a lot of these organizations were working together. Also, what we found out is that even those organizations didn't have any funding or resources, they were getting phone calls, they were getting inquiries from some of the users about, getting support, because as we know very well, the pandemic came and nobody was prepared. The council wasn't prepared. A lot of people are not prepared because it's something that has never been seen before. So in the event of supporting the users, one of the organizations came across a family that are living actually in a shed in Ealing. And so it's a husband and wife with 2 children under the age of 5. And the husband and wife are undocumented at the moment. And the person who was living in that property where the shed was using them as modern day slaves, So basically, and the husband, because this gentleman has a construction company, so when they were, when this organization found this family, they also found that the husband had some sort of glass stuck in his eyes because he got an accident at work, and he was afraid to go to to Ealing hospital or emergency because it's undocumented. So luckily, the organization that is involved was able to support this family, and again, it just shows how the council can work with the sector. So basically, Ealing Social Services got involved, and the family were put, they were put up in accommodation, and also provided with money for subsistence living, which I think was a very good thing. Now that family is being, continuously supported at the moment. The other issue that I think, as I said, there's a lot of examples, but this is just two. But this second one is quite shocking and something we see a lot. So these groups are able to identify, actually one of the organizations is able to identify 17 individuals from the BME communities that had severe, even clinical mental health afflictions. And unfortunately, they were not known. Some of them were known to the system, but majority were not known to the system. And because of the nature of the pandemic, because of the lockdown, these individuals are actually outside. One of the gentlemen, one of the person that was found, that was supported, he was actually ended up being in a fight with a police officer, and he was sectioned under the Mental Health Act. But then, I think there's support now for that family and the gentleman. So identification of these 17 individuals just shows that there's a lot of people out there in Ealing, especially, who for different reasons, they're actually not seen by the kind of support systems around mental health. Thank you, Anna. Next slide, please. So with the survey itself, initially we thought it would survey a few number, but we're able to survey up to 342 residents, and so basically we surveyed some of the different communities in Ealing. So for example, the Sri Lankan community, Somali community, South Sudanese, the Syrian community, Punjabi speaking community, and so it kind of very and also the Nepalese community. So the way the methodology of the survey, we decided to make it very short and kind of very focused. So because of social distancing, and so we were doing things like, for example, when we were dropping food to some of these individuals, we were able to use the opportunity to carry out the survey. So we used different ways, the phone, texting, and even by email. And so we got the 342 residents who took part. And the next slide, please. So we found that those who were surveyed, majority fell between the ages of 46 and 65 years old, and more than 300 participants have indicated that COVID-19 has negatively affected their mental health state, and just over 250 participants each knows someone that has died as a direct result of contracting COVID-19. 250 and more than 100 participants have indicated that they will require mental health and well-being support, and support to understand up-to-date official COVID-19 instructions. So again, we see mental health as an issue. We see a lot of people who need support, but again, what kind of support do we have in Ealing in terms of mental health? And that's another thing, because, from GOSAT's point of view, we've always said that in Ealing, for example, we've got IAP services, which we know majority of the BME community do not access, just because of the nature of how, that service is provided. The issue around trauma, we have a lot of people who come from Syria, from Afghanistan, and unfortunately, the services available are not designed to support them. And also the issue around COVID-19 protocols and instructions. people are still confused about all that. So how do we probably work together on that? And if you can go to the next slide, please. Now, we've identified, 5 points to tackling BME inequalities in Ealing. And this is something we want to push and hopefully hope that we can work with everybody. Because also we understand that there's been a lot of, research, and even at the moment, I just received a request to be part of another survey on the impact of COVID-19. Now, the difference of this survey, or for example, this report, is that it's actually led by BME-led organizations. That's actually one of the unique kind of perspective of this report. Secondly, these organizations continue to experience inequalities themselves, but also they see on a daily basis the different types of inequalities. So these 5 points, the first one is the health and social care inequalities. And here, for example, we have a lot of examples, a lot of experiences on how some systems are broken and some systems need maybe more kind of joint up work to make it, we hear things like, for example, like co-designing services. We hear things about user-led services, but actually this is something that's implemented from the top. And we see that a lot of organizations or even individuals are not properly consulted. So it's again, is a huge area, but we hope to work with everybody to see how we can find solutions around these issues. Housing and welfare rights. Now here again, there's so much that we're dealing with. Even at the moment, GOSAD as an organization, we see about 20 to 30 people a week. So we actually open our offices, and a lot of people are coming with issues around, rent arrears. People are coming around issues around universal credit. So some people, for example, were given advance money for universal credit, and the money is being asked back, and there's a lot of now the issue around, for example, housing. There's something we put on the report. You just mentioned it. We have an issue around, for example, the policies, and this again goes to the third point: local policy strategies and associated initiatives. So we have a family of 3 sisters who've lost their father to COVID-19, and their father was a key worker. Now, because of the Locality Act 2011, children of deceased parents, for example, cannot succeed the property. Now, unfortunately, we don't know how many young people in Ealing have been affected by this kind of rule. Now, we don't think it's fair. I'll just give an example. If somebody has a boyfriend or girlfriend, and the person lives with you for more than 12 months, that person actually qualifies to succeed the property, but not the children. So how can that be fair? So we are planning to do a big campaign around this Locality Act 2011, especially in this particular area. And also we want to seek more support from the council to use their discretion, because, for example, this family, we still actually going through processes with the council to see if they can use discretion for them to stay in their in the house where they grew up in. This has caused a lot of mental health problems with these young girls. They're under the age of 25, and they want to stay in the same property because it gives memories of their father. And also the other thing is that they're not on welfare, so basically they are able to pay the rent. But of course, the council, still maybe deciding on this. Now, one of the other thing about this situation is that the council hasn't got at the moment a tenancy strategy. Now, part of the Locality Act 2011, there's a requirement by the council to have a tenancy strategy, and that tenancy strategy is supposed to be used to create, for example, the homelessness strategy. So the council at the moment doesn't have one at the moment. So we are thinking, if there's no policy in place, how can they decide, for example, to support this family? So we think, more needs to be done with the council in terms of, being fair. But again, that's something else for debate. Now, with the policies and strategies, again, we see things, for example, about, let's say, the local strategic partnership, where we see a lot of documents written on different things and actions, but we don't see the results of it. So, for example, GOSAD was involved in a project in Northolt, which was very successful. Now, we were not invited to talk at the strategic level to give our, our perspective of how successful or the kind of challenges that the project had. But unfortunately, other people were able to present this information, which again we found that wrong information was given to the LSP. Also, there's an issue around who sits on those kind of boards. So we see, for example, as most of you know, I think by 2025, the BME community in Ealing will account to about 54% of the population. But we know sometimes in some of these kind of forums or strategic groups, we don't see people from these communities being over there. And it doesn't have to be tokenistic. There are people actually with talent, with experience, but we don't see them. Another example is we have the Let's Go Southall project, which unfortunately it was set up. I mean, the community groups in Ealing and in Southall, because of them, this funding became successful. Now, when the funding became successful, for almost 9 months, we didn't hear anything from the council or CCG. Public Health. And again, we are worried that this project, will actually not deliver the promises that it kind of promised. And the other point is bridging the digital divide. Again, we see there's a lot of problem. We've been, especially from GOSAD, we've been banging on this for a long time, talking about, for example, things like the My Account, things like, all the other portals, for example, Universal Credit. So we reckon that maybe up to 18 to 20% of residents are digitally excluded. GOSAD has been running UK Online Center for the last 12 years, and we've had thousands of people to become digitally included. But we think sometimes, we see surveys being done, we see consultations being done, and because when you interpret documents, it doesn't mean actually it reaches every community. We have people from similar communities who are actually illiterate, so they cannot even read and write in their own languages. So the digital divide actually it's really wide. And for example, the My Account, which we know is a council's kind of preferred way of residents to, we think is not user friendly. We've tested it and it's not user friendly. Actually, the previous version was slightly better. And again, we don't know how these consultations happen and who actually consulted to support, streamlining the digital, and also with the pandemic, we've had a lot of families, with no internet connection, no, devices to use. Kids cannot, are supposed to be doing the homework from home, but they don't have the support. So we think with the support of the council, if we can all work together and make sure that, because we don't know about this pandemic, we don't know what's going to happen next time. So how do we actually work together to make sure that those families are supported? And the last point is support for recognition of BAME-led organizations. Unfortunately, in Ealing, over the years, there's a lot of groups that we know that are no longer there. And unfortunately also is we got a compact document, which I'm always a bit kind of skeptical about it because it talks about what needs to happen between the sector and the council, but unfortunately we don't see the actions. And also the last compact document that was decided upon, GOSAD and other organizations were not properly consulted about that. And also the other thing is some of these organizations deliver amazing work. They're working with their own communities. They receive a lot of users with a lot of issues, but they're underfunded. They are not properly recognized, as I said, and also we know, for example, we have the Ealing, I think now it's called Ealing and Hounslow CVS, I think Ealing Community Network. Unfortunately, when you have this kind of, we call them second-tier organizations, it doesn't mean that what they say represents every section of the voluntary sector. And for some years, and up to now, actually, what they say is taken on face value. Now, the problem also is that like Ealing CBS, for example, they're doing amazing work, for example, but over the last few years, in terms of austerity measures and all that, we see this kind of organization delivering frontline work. So the work that was supposed to be delivered by small organizations are now being delivered by these big organizations, whose responsibility actually is to build the capacity of the smaller groups who are specialized in the areas. And I think, there need to be that kind of discussion where, the council, for example, should look beyond and above just, Southern Community Alliance or Ealing CVS or is it Acton Forum? So, it's just my, my kind of advice that we need to be more focused on a lot of the BME community. For example, the Nepalese community who live in Ealing, most of them have fought for Britain. They've been left on their own devices, and we find, so we have, for example, 80 of those individuals we're supporting at the moment. Some of them are decorated, people within, the army, but, they are digitally excluded. English, again, is a problem, but we don't see a lot of support. Thank you very much, and I'll take any questions maybe now or later.
Thank you, Shimake, and obviously both there in your presentation and in your survey report, you've raised some very important issues, and also some quite concerning case studies as well, which I think certainly we as a council, and I'm sure I speak for other partners, we would want to understand how we can improve things so that we can work together to make sure that those kind of things don't happen. So thank you very much. Who's got any questions that they want to ask Shimake at all? If you, Simon Crawford, I can see your hand up.
Okay, I didn't realise it was up, but I did have a question that I've just sent. So when you talk about the digital divide in particular, what sort of things would make a difference, do you think, in terms of how we could help to address that? Is it about the communication we put out? Is it about the infrastructure and equipment, etc.?
I think I'm going to be a bit like a devil's advocate at the moment, if you don't mind. Now, because we deal a lot with the council, we know the council is the biggest employer of of residents, for example. And we've seen, for example, the council have invested heavily on digital support for their staff members, which I think is the right thing to do. Now, this is a challenge I'm giving to any of you councillors here. When we are back from the restrictions, if some of you can just spend some time downstairs and just observe, people who are coming in for support. Now, unfortunately, people are coming in and they're told, "Oh, we got computers there, go and upload." I've been there a few times where I'm helping maybe somebody, and I find myself actually helping somebody who I don't know to actually try to upload documents. But the problem with that is that there's issue around GDPR. So, the person might want you to see their passwords and all that, and you don't want to do that. So people don't even have, they don't even have, email accounts. So what you are saying, for example, you've got organizations like GOSAD and others who on a daily basis, actually, for example, GOSAD, we're getting our funding outside of Ealing to support residents, to empower them in terms of digital inclusion. Now, the other thing also is we see, for example, surveys being done where it's about digital surveys and not, So again, we think it's something that the council can work with the sector and mobilize people, because mostly we use volunteers. It's not that the charity, the sector needs a lot of funding all the time, but it's just about streamlining things and working. Because I think in Ealing we need maybe a forum around digital inclusion, and I think from that forum we will see the divide. We know, for example, sorry, just I might talk too much, but we have a lot of people who work in the gig economy. So these are people who are carers, people who work in maybe Uber Eats and all that and delivery. Now the problem with the type of work they do is that the hours keep changing. Now with the council, you need to go online and apply for change of circumstances, basically. So let's say if this week I've done 20 hours, last week I've done 10 hours. So a lot of people that we're seeing who work with the care industry are digitally excluded. Now they've got a 4-week period, a 4-week window to declare the change of circumstances. If they don't do that, then they're penalized. Now, the penalties are things like overpayment of house bills and council tax. And we see this a lot, where, we call this group of people, for example, the working poor, where, they're working, but then they cannot maintain, because they need to get up welfare to work support. Now, the council sits on a lot of data, and that's what I keep saying. I know the council is doing a commission on inequalities in Ealing. Now, in our report, we said, the council should look internally. So, for example, there's a lot of people who need that support to upload things or to put something online, but they haven't done that, and they get penalized. And we know some of them actually have lost their property because of, things have accumulated, and so there's a lot that needs to be done. But we need
Okay, thanks. And I presume the same applies to health, because increasingly we're looking at more virtual outpatient clinics and more communication digitally and more electronic records. So it's the same challenge for health in terms of engaging with them as well.
Yes, and I mean, I got contacted by somebody from the ONS, so about the censorship. So Ealing. So there's a group in Ealing that are going to do the censorship.
Okay.
I got contacted, and I was a bit crossed with them because they have a target of the 175% of Ealing residents to do their censorship online. And I was asking, okay, how are you going to do that? And then I was told that, I think we're going to use the library. So I had to tell them, look, a lot of people are digitally excluded, and you have this kind of target, you might actually end up losing. I mean, you might end up actually not counting a lot of people.
Okay.
That's a concern, And of course, if you don't count the people, then what happens if the council, might actually not know all the different.
Okay, thank you very much. Thank you. We'll need to take that on board in our strategies and policies. So, in terms of how we can respond, thank you.
Thank you, Simon.
Thank you, Simon. I can't see any other hands up at the minute. So
sorry, Julian, I did put my hand up physically because I don't seem to have a hand button.
Okay. If you go into the participants part of Zoom, right at the bottom of the screen, you'll see a raise hand icon.
Okay, thank you.
I'll
do that Sarah. In future.
Go ahead.
Hello, I'm Sarah Rushton. I'm from West London Trust, and we deliver mental health and community services in Ealing. And I found what you had to say really quite compelling. With the mental health services, I think we are really starting to understand that our access just doesn't go deep enough into some of the communities who really we're not outreaching to. And the long-term plan has given us more investment for mental health. So we would very much like to work with you and some of the other organisations that you mentioned this evening to try and work out how we do deliver the right type of interventions into communities and support and give much better support than we have done previously. So perhaps we could pick up some contact later and I can put you in touch with some of the people that are leading on that.
Yeah, thanks. Actually, I'm involved in the Mint process at the moment.
You are fantastic.
And the thing is that we see mental health as we don't have to wait until things become, very bad. So we have people with low-level mental health, that can, for example, if you look at welfare to right programs, disability-related benefits, because of the new regime, a lot of people, their disability-related benefits are actually denied. Now, what that causes is a lot of mental health anguish. So because we have an advice program, when they came to us, we have designed a program where we try and pick all the issues of in terms of making the appeal, because as you know, there's no legal aid for this kind of support. So people, they're deemed, for example, somebody with disability on a wheelchair and is able to raise one hand in the air is found to be fit for work. So that kind of a person will have some sort of mental health anguish. But if they get the support and the welfare is being stated, that takes away that kind of worry and anxiety. So our argument is that, we should not wait until things become, someone becomes sectional. And we have a lot of ideas and we put things in practice that I think can work. So hopefully, we can act together on that.
Thank you, Shamake, and thank you, Sarah, for that contribution as well. Can on behalf of the Health and Wellbeing Board, can I thank you, Shamake, for the work that you've done and all the groups that were associated with that work as well. It certainly is, as Sarah's just said, compelling. The digital divide points that you've just made highlight what is really a significant challenge for all of us to ensure that we allow everyone equal access to our organisations and our services. And we've clearly got work to do, and you can help us with that. So thank you very, very much. Let's move on now to our public questions. I can see Roy Willis poised with his unmute button, ready to go. So Roy, do you want to ask your first question?
Well, actually, I was going to ask a second question because it does relate to the BAME report. Is that okay if I change the order around and ask a second question?
Well, hopefully we can be nimble on our feet. Roy, go on.
Yeah. So I'm Roy Willis, chair of Ealing Reclaim Social Care Action Group, and obviously we are welcoming the report by the 6 BME organisations on the impact of COVID-19 on Ealing's BME communities. And note, obviously, that several recommendations are about issues that we've previously raised in terms of the value of maintaining services like Ealing Together and other voluntary and community groups or services. The need to bridge the digital divide and the hidden nature of some inequalities. However, the question I wanted to ask was regarding the impact of COVID-19 on BAME health and social care workers in terms of the sacrifices that they've had to make and the dedication of their work, which is much appreciated throughout the community. But we were wondering what steps the council has taken to ensure appropriate risk assessments by managers and employers, and ensuring statutory sick pay or the equivalent for those workers that have to isolate or stay away from work, and the making sure that the London Living Wage is applied to all domiciliary and residential care workers. Thank you.
Thank you, Roy. Kerry Stevens, our Adult Services Director.
Thank you for the question, Roy, and thank you, Chair. So the Council's been working in close partnership with the provider and the voluntary sector throughout the COVID crisis, and we've been working with them in line with national guidance regarding allocation of the Infection Control Fund, which is specifically targeted at the provider sector to support and reduce the risk to staff working in these very important roles within the care sector. The Council has also been supporting the provider sector with resilience payments, and over £300,000 has been allocated to the provider sector to support them with their financial viability in light of the significant challenges. The Council has also been working notably with daycare providers recently to support them to ensure that their customers and their staff are working in COVID secure environments where services are continuing to run. So I think it's an absolutely valid question, Roy, and we've been working with partners throughout and in line with national guidance. Thank you, Chair.
Thank you, Kerry. And just on the London living wage issue for domiciliary care staff, certainly that's something that our scrutiny panel recommended to Cabinet, that we sign the ethical care charter, which includes that commitment to living wage, and as a Cabinet we have agreed that, and where we're at is and it has been put back by COVID, unfortunately, but we have been scoping out and have got some work that's currently being done to look at what the cost implications would be of that implementation of that decision that we've made as Council's Cabinet. So, Roy, do you want to ask your first question now?
Yes, thank you, Chair. Further to discussions at previous health and wellbeing boards and also other committees, we'd like to ask what arrangements have been made for the visiting of residents in care homes in the borough by relatives. Has support been provided for practical changes to layout, probably financial support, provision of PPE and or testing to allow COVID-safe visiting by relatives? And is the issue of visiting monitored regularly for each of the care homes? Really, what we're asking is what is obviously coming to the fore in national discussions, but we're wanting to know what's happening locally and whether it's being good practices being put forward in order to allow relatives to support to visit their residents in care homes throughout the borough. Thank you.
Thank you, Roy. Kerry.
Thank you, Roy. Thank you, Chair. We've been working very closely with the care homes, Roy, as I mentioned earlier, and also providing additional funding to support them with visiting. We've been sharing best practice within our care home managers group, where we meet fortnightly, and also providing oversight of the care home sector in terms of our bi-weekly meetings with a multidisciplinary team of partners to look at the care home sector. The council's maintaining very close partnerships with the Care Quality Commission, who have the registration responsibilities for the care home sector, and they're part of our multidisciplinary team. So we continue to work very closely. We're very conscious of the impacts and the benefits of visiting, but also clear that we're following national guidelines. Thank you, Chair.
Thank you, Kerry. And also just to say, Roy, we have signed up as a council to have the rapid asymptomatic testing kits that the government have offered to us, and we were looking to prioritise those rapid tests to care homes and looking at how we might pilot that. That's already been moving ahead, though, in other boroughs that are ahead of us, and the government are now saying that they are looking to have regular testing for I believe it's 2 visitors per week to go to visit someone in a care home in a safe way, having had that test before they go. So we are mindful that this is a really important thing, and we want to make it possible for people to visit their relatives in their care home. You got a third question, Roy?
Yes, indeed.
Go ahead.
Yep. Okay. the Health Watch report and to some extent the BAME report also discussed a number of recommendations on health and social care services in relation to mental health and well-being. But I think we're all concerned that community mental health resources, appropriate counselling and support are severely restricted due to lack of funding and or staffing shortages. What steps are being taken to engage with local groups, BAME and others to explore what resources are needed to check regularly on the welfare and support of some of our most vulnerable residents and their carers? Thank you.
Thank
Go ahead,
you.
Kerry. Thank you, Roy.
Thank you, Roy. Thank you, Chair. So the council and a wide range of partners had a mental health summit in October, which was led by Councillor Ryle, a cabinet member, to look at the issues of the impact of COVID on the wider community, but also focusing within the subgroup on the impact of the COVID crisis on the wider BAME community. The action planning from that group is being fed through to our mental health and suicide prevention group, and it will have oversight of the action planning that we have developed from the mental health summit. Thank you, Roy. Yeah.
Thank you very much, Roy. We've got 3 questions from Eric Leach, but I don't believe Eric is with us, so I'll read them out and we'll answer them, notwithstanding, because they are important questions, which I'm sure there is interest in finding the answers to. So the first one is, what arrangements, if any, has Ealing Council Public Health entered into with regards to the Pfizer mass vaccination programme? Our Director of Public Health, Anna Bryden, will answer this one. Anna.
Thank you, Chair. So just to say, the NHS is leading on a programme and with support from the council. So we don't have any direct arrangements with the vaccination companies. The council is providing support on a number of aspects for this. Working closely with the NHS, so for example, identifying sites for vaccination clinics, and also further down the line about communications and community engagement with our local residents. And just to be clear, we haven't got any firm dates yet for vaccination programmes, as we're just waiting for those final approval of any of the potential vaccines. Thanks, Chair.
Thanks, Anna. The second question was, how many people are employed by Ealing Council Public Health to contact trace those who have come in contact with a COVID-19 infected person? Anna again.
Thank you, Chair. I'll just start this one, but I think Councillor Ryle also might want to come in on this. So we've only recently launched our service. I think it was on the 12th of November. So we've got a small team of internal council staff running this, and really to get it going, see how it goes, and then potentially expand it further down the line. But Councillor Ryle, I don't know if you want to come in on this one.
Yes. Hello. Oh dear. I think my video is not working.
We can hear
you. Can you hear me?
Yeah,
oh,
we can hear you.
Okay. So basically, all I want to add to that is that the test and trace, the system is very, I mean, it's only been going a few days, and we are going to continue to review the needs and therefore adapt accordingly. I understand at the moment we have around 15 people that we're using for this service, and they're all people from within the council who have been redeployed, and we've done that because we think they know the community best. And of course this will be kept under constant review, and it will be scaled up and scaled down as and when we need to. I hope that's helpful.
Yeah, thank you, Minda. That's very helpful. I believe that there are 4 supervisors who work with that team of 15 as well. So Eric's question actually talked about those who've come in contact with COVID-19 infected person. Now, we are trying to contact the actual COVID positive people, and as yet, local authorities, enhanced contact tracing teams have not been given the role to contact the contacts of the positive people. So it makes sense for us to do that, but as yet that's not happened. The final question from Eric Leach is, what is Ealing Council Public Health's estimate of those who are successfully contacted as COVID-19 contacts who successfully self-isolate? Anna and Councillor
Thank you, Chair. So both nationally and in Ealing, we are seeing quite high rates of people who are diagnosed positive being contacted by the overall NHS test and trace service. So that's at about 75%, I think. In terms of people who are contacts of those people diagnosed positive, that's lower. So both nationally and locally for us in Ealing, that's about 60% of all contacts are successfully followed up. The good question in terms of how many actually self-isolate, we don't have specific figures for that nationally. There are estimates by the NHS Test and Trace Service, it's about 50%, but we don't know the exact figures, and we don't know what that is locally. I think importantly, a lot of London councils, including Ealing, have been doing some work with local communities to really try and find out the barriers to self-isolation, which might be things like not being able to go to work, for example, or not feeling that they can get food into their house. We are looking at that information in Ealing and sharing it across lots of different partners, and really trying to identify any further work that can be done on top of what we're already doing to support residents that do need to self-isolate. Thank you, Chair.
Thank you very much. I've now got some questions from Eve Turner. I think I saw you on the call, Eve.
Right, hi. Can you hear me?
Yep, we can hear you.
I wasn't expecting to be able to ask my question until the end of the meeting, but obviously you've changed it around. So my question would really be part of the discussion, if there is going to be one, on the single CCG, but I'll read it out. So Ealing Council, along with other local authorities and campaigners, did raise serious concerns about the move to a single CCG. These concerns, as far as I'm aware, were never addressed. And as I understand it, the single CCG is now going ahead in April 2021. However, in the meantime, local CCGs are hardly meeting. I think there's been about 2 or 3 meetings this year, maybe only 2. And the reality is that strategic decisions are being taken by the North West London Integrated Care System, or ICS. It's unclear where this body, and it's not just the one in North West London, but across the country, actually, which meets behind closed doors, actually derives its considerable authority. So my first question is Ealing Council or any other local authority involved in any way as part of the ICS or in consultation with the ICS? And if so, please, can you specify how this is working? That's my first question.
Thanks, Eve. So on taking it from that last part of your question first, there is, and I think I'll probably answer some of the later questions when I answer this. There's a monthly planning meeting between local authority leaders, chief executives and the ICS leadership from the local NHS, and that steers progress on the development of the ICS and discusses key issues and such as COVID-19 pandemic, winter planning and reducing inequalities across North West London. Now, there's a question later about there's only a single person from the local authorities on the ICS. However, we have these monthly planning meetings where every council leader and every chief executive is on those meetings, and to be honest, yeah, we are happy with that, because actually that's giving us a lot more access and influence than we've had previously, and that will continue, and I think that will become when we're up and running statutorily next year, that will be part of the way things move forward. But Mahini, did you want to add anything from the CCG? Or...
Yeah, so I think I think the council and local authorities are far more engaged with the process than they were previously. As you say, you've got the monthly meeting. There is an ICS exec which meets on a weekly basis, and Sean Harris, who is the Chief Exec of Harrow Council, is the representative there. We had our partnership board today, which was chaired by Penny Dash, the ICS chair, and you've got local authority and Chief Exec representation there. Including that, I would say that local authority and public health is represented in all the working groups which happen. So the working group I know, the board I know very well, children and young people. So Judith is part of the exec and the board, and is fully engaged. So I think it's working at all levels, and everything that the NHS proposes is discussed with yourselves and with the directors. And similarly, when we look at during COVID, the COVID surveillance group, which is held once a week, which I attend, you've got all the directors of public health who attend, and we share information. So I would say there is more involvement than there has been, and actually where we are doing things as opposed to just talking about governance, we're actually doing things for the benefit of people here and now, whether it's in discharge to assess, whether it is in getting people out of hospital where it needs to so that we can keep the acute capacity needed, or whether it is in children and young people. I think people are really quite well engaged in the system. Regarding the single CCG, as you know, this decision was taken by a governing body, and we've also got a governing body in common tomorrow where we are recommending, or we're going to talk about our CCG constitution, and which will then go to a member practices vote in 10 days time, with the aim of having a single CCG in place from April 21.
I would say also, Eve, that there are still concerns that we have as the local council, particularly around the arrangements within Ealing, and there are still ongoing discussions about that. Yeah.
I wonder, Chair, if I could briefly come back. I could speak about this for but I won't.
Yeah.
I think for us, I mean, so for example, I could say I wrote 6 weeks ago to the Chief Executive of the ICS about our concerns about the introduction of a 1-1-1 system, and I've had no reply. And that is, I'm afraid, a bit of an experience that we have in relation to the ICS, because the ICS, at least when we had a collaboration of CCGs, we could go along to the meetings, we could put in questions, we could get answers. And I think one of the big issues is there's a complete lack of, I know I'm pleased that obviously that meetings are taking place with local authorities, that's a good thing. But from the point of view of public, of campaigns and people like us, we don't feel there's any transparency. We feel that decision-making has been removed very much from us, decision-making about things like future funding. We know that the ICS is going to have a major role in discussing funding for trust. Decisions about Ealing Hospital were taken at the North West London sector level, and so on. And I think, bearing in mind the point that was made earlier by Shamaki, I actually think for BMA communities, it rather moves all that decision-making further and further away from local people, and does mean that those concerns that have been addressed just don't happen. I mean, maybe things will be slightly better if ICSs get some statutory authority next year, but that's by no means guaranteed. So I think the question of democracy, accountability and transparency remain a major concern for us.
And I think that those are points well made. Did you want to respond to the transparency point.
So I think that there are a level of 2 levels. We have got Sarah and Simon Crawford here as well. So we are level 4 pandemic, and the changes which happen for the Ealing hospital site and the 111 was discussed at the across the providers. Simon, I don't know if you want to come in on that, on the 111 pilot and so on. And actually that we are in a level 4 pandemic, and what we are doing is to maintain our NHS services so that we can continue to deliver not just on COVID, but continue to deliver our elective care right through this. And I think it is important to stress that this time in the second wave, the NHS is not pausing any elective activity. So I think all the decisions that are being taken are to maintain the safety of the population and the staff. I don't know if Simon wants to add anything to that.
Yes, absolutely. Those decisions, while supported by the ICS, were clearly initiated by the Trust in terms of making a judgment in terms of delivering safe services for patients. So we absolutely originated those decision makings, and they were signed off as part of the ICS, as part of the discussions we have with them in terms of the mutual aid and mutual support. So there's some things we have discussions about. So for instance, last week, we got support for a divert from Northwick Park and intelligence conveyancing around Ealing, around getting mutual support across the ICS, which meant that we didn't have to cancel any elective activity or surgical procedures, which if we weren't working as a collaborative in the way that we are, that would have a direct impact on patient care and those patients who were due to come in for surgery. But by working effectively with the LAS and the whole system and agreeing with the other hospitals how they would take and respond to those patients, it's more effective in terms of joined up care for patients across northwest London. Clearly, in an ideal world, maybe we'd be able to accommodate those all the time at Ealing, or all the time at Northwick Park, or all the time at Hillingdon. But the reality is we do have peaks and demands, and working as a collaborative as an ICS is more effectively in us managing the care safely across the sector. In terms of the level 4, though, there are some things that we clearly change at Ealing, and I know you're concerned about the trauma and orthopedics. Eve, you know, we are still at a level 4. We are still keeping that under review, but at the moment, because we're in a level 4, we're not intending to change that in the short term. But once we come out of level 4, and once the COVID pressures relent, then we will relook at that in the new year.
Thank you very much. So you were right in that we've got a single CCG agenda item at 13. We've kind of covered it in answering your questions, but you've got another question about having an agenda item on the ICS, Eve.
Yeah, because part of my question you've done, I mean, I don't really think my question was answered on transparency, but maybe that's a question for another day. I'm conscious that you've got a lot of time. Yes, I just wondered if the council would consider making this an agenda item, because I think it's not just about single CCG, it is about the ICS, and I would like to ask if you consider making it an actual proper agenda item when we can hear more about the ICS and how it's operating and how the public can engage with it. So.
Yeah, and I think that's a very sensible thing that we would do. We will do. When we get to that item, looking at the forward plan, we can put something in there to do that. And what I would say, Eve, as well, is that my kind of allowing these questions at the Health and Wellbeing Board is hopefully giving you some opportunity to ask questions and give some transparency going forward. But I accept that's not sufficient, and that there does need to be more. So fine. I've got
Julian, I wonder if just one thing. Could I ask, since Mahini is here, if Mahini, I have actually sent Mahini the questions about A&E 11 first, although they were directed to Leslie Watts. So I wonder if she could use her good offices to see, in the interest of transparency and so on, that I get some answers to those questions.
Yeah.
Because it's been nearly 6 weeks, so I would be grateful.
Sure, I'll
respond to that, Mahini.
I've messaged her to get onto it, so don't worry.
Yeah.
Thank you very much.
So Eve, just to confirm that it is in hand, it's just the officers concerned that are required to respond have been tied up in responding to the Wave 2 pandemic. So apologies, we recognise there is a response due to you.
Thanks very much, Dara. Thank you.
And I know Clara's question is about the single CCG as well. So let's take your question, Clara, next.
Can you hear me?
Yes, can hear you loud and clear.
Right. So my question is, their mission is to reduce duplication, achieve best value, effective working in the NHS and local authorities, and improve reaction time. Wonderful words, but what do they mean? The individual CCGs will continue as stated. The single CCG is not a statutory body. Is the single CCG not just another bureaucratic layer? Justify more specifically what improvement you plan to achieve with some figures.
Chair, should I take this?
Yeah, go ahead.
Okay, so thank you, Clara. So a couple of things. The single CCG will be a statutory body and there will be no individual CCGs in the borough. What is also clear is, and the single CCG will fulfill the complete statutory responsibilities of the 8 CCGs and will discharge its functions through various committees, and one of them will be the borough committee in each borough. And this borough committee will be the CCG staff, will be working along with the clinical leadership, who will work hand in hand with our local authority, our public health colleagues, community services and community mental health services, and our local GP practices to form the integrated care partnership, which effectively will be the way we are able to develop a consistency and quality of service across in the borough. The fact that we need to work on a place-based approach, because that is where care is provided, continues to be in place. What the single CCG allows us to do is to commission for a population and address the issue of resources and workforce for the entire population, as opposed to just by each individual borough. So I think the figures and the improvement on that, you will start to, I don't have the figures on hand at this point, but we have been working as you know, in Northwest London as a 5 and a 3 for many years, and really as a 1 for the last 2 years. This formalizes that process and actually removes some of the duplication which currently exists, because we have 8 statutory bodies. Now we'll be having 1. I think the issue about having local public visible accountability is real and proper. And as the system matures, that will absolutely need to be addressed. So I completely hear that.
Okay. Thank you, Mahini. Clara, your second question, which was about only having 1 local authority member representing the 8 local authorities on the single CCG. I hope that I answered that previously when I talked about this monthly meeting that all council leaders and all chief executives are on. But are you happy that we've addressed that one?
No, I can address that. Actually, on the papers that are coming tomorrow, it has been agreed that there will be 2 local authority representatives on the CCG governing body. So that has already been addressed.
Very good. That was our request. Yeah. So thank you for that.
That's in the papers that's coming tomorrow.
Okay,
I don't think that's a partnership, but you will have to make your case. I have one more question, and that's concerning the role of public health. The single public health member on the single CCG has no voting rights, effective public health saves more lives than any other health measures. Ealing has a poor vaccination record and has curtailed smoking advice in 2018. According to the Office of National Statistics, 95,000 people in the UK die related to smoking. So it's an important factor. Surely the public health member on the single CCG should at least have a vote, and probably there ought to be more than one.
Should I start and then I can chair and then I can come in? So if you look at the current public health, as you know, moved to local authority in it was in 2010, and the voting members of the governing body are CCG officers, lay members, and clinicians. What we know is that public health colleagues and ourselves work very closely together, and the services that the CCG Commission is based on the Joint Strategic Needs Assessment that is undertaken by our public health colleagues. Actually, what is interesting is during COVID, we have absolutely started working together even more. As I said, I talked about the COVID surveillance group. We have an Ealing Gold and Silver Command where again Anna and her colleagues attend, where we meet on a weekly basis. And I think the whole issue around vaccinations is completely well understood and is now factored into the primary care networks outcomes that they would be needing to achieve going forward. So I think what is true is public health work closely together, but the CCG is an NHS statutory body. And I don't know if you wanted to add anything on our joint working.
Well, I think the public health member should have a vote. Otherwise, all they can do is advise.
Hang on,
and we've
hang on, Clara. You've asked your question. Let Anna, the public health director, answer.
Oh, sorry.
Go ahead, Anna.
Thank you, Chair, and thank you, Clara, for raising the question. I just wanted to really add to what Mahini was saying, that we are working incredibly closely with our CCG and the wider NHS colleagues, and that includes on a wide range of public health issues, and especially at the moment with COVID. So I do want to kind of just the actual CCG governance. I think that's something CCG colleagues on, but I think it is just important to note how closely we are working together and how much we do discuss public health issues in those forums. Thank you.
Thank you, Anna. So that ends the public questions. Was there anything, Mahini, that you wanted to add in terms of that item 13 on the single CCG? I think we've probably covered it all. Or?
Yeah, I think so. And I think I've explained everything. Thank you very much, Chair. Thank you.
Fine, thank you. So I'm sorry I'm jumping all over the agenda here. Let's go back to pretty much the front end of the agenda again. We've dealt with item 7. We've got item 8, COVID-19 inequalities, and then we've got the COVID-19 presentation in Ealing. Anna, were you going to deal with those ones? Or Wendy?
Thank you. Thank you, Chair. So Wendy's going to talk us through the integrated impact assessment, the early findings under that inequalities item, and then I'll do a very brief update on the COVID-19 situation.
Fine, thank you. Over to you, Wendy.
Thank you very much, Chair. So what I'd like to do this evening is just briefly talk you through the early findings from the integrated impact assessment that we're doing on COVID-19 inequalities, to share the priorities for the next stage of the work, and then to also share with you the emerging recommendations that are coming out of the work so far. You'll recall we talked about why we were doing this at the last meeting, but I just wanted to draw your attention to the 3 bullet points at the end. The first one is to say the process we're using is very, we're trying to use, I'm not sure dynamic process is quite the right expression, but we're trying to learn from the findings as they emerge from the work and feed those findings into our immediate response. And also to make clear that the recommendations coming out of the work are for the short, medium and the long term. So particularly the short-term actions, as I say, there's lots of examples as I go through where you'll see that this work is actually influencing and bringing out recommendations for how we handle the second wave that we're in at the moment. Most importantly, and it was great that we heard from GOSAD at the beginning of the meeting, we need to make sure that the work that we're developing is shared with our communities and that we listen to their experiences so that we can build that into the findings and sort of co-produce those recommendations together. So the structure of the first phase of the report looks like this. We've used these 6 disparities that PHE described in the report that they published in June, or inequalities as we would prefer to call them, to structure the analysis that we've done. We've looked at sort of differences by age and sex, by people with health term conditions, people living in deprived communities, people of different ethnicities, people living in urban environments, which obviously pretty much everyone in Ealing, and frontline occupations. And we've looked at what the evidence so far is telling us. We've looked at our local analysis, but as I say, really importantly, we want to make sure that we're understanding what our communities are telling us as well. So just looking at the age and sex issues first, nationally, we know that the largest disparity found in the first wave was related to age. Almost amongst those diagnosed with COVID-19, people over 80 were 70 times more likely to die than people under 40. And when we look at our local Ealing information, we know that people admitted to hospital with COVID-19 in Ealing who were over 65, that came to 54% of all hospital admissions, and that compares to 13% of the overall population. So quite a lot of overrepresentation there. We also know from national work that working age males diagnosed with COVID-19 were twice as likely to die as females. And again, looking at hospital data that we've got in Ealing, men accounted for 63.9% of all the patients who sadly died in hospital, compared to women who accounted for 36.1%. Again, looking at Ealing information, 78.6% of Ealing residents who died in hospital were over 65, with 51% being over 75. So nationally, from the report, and again, I think this is coming out in the qualitative discussions that we're having, young people, whilst seem to suffer less severe illness from COVID, are potentially suffering much more from the economic impacts and have increased risk of long-term unemployment. We then went on to look at people with long-term health conditions, and nationally, people living with health conditions such as diabetes, high blood pressure, breathing difficulties such as COPD and dementia are more likely to die from COVID-19 than people with no underlying health conditions. And again, looking at hospital admissions, 93% of Ealing residents admitted to hospital with COVID-19 had one or more health conditions. I just want to draw out as well messages about diabetes. Nationally, 21% of people who died from COVID-19 had diabetes on the death certificate. This is when we look at this for Ealing, it goes up to 34%. So again, we sort of would expect that being one of the highest prevalence areas in the country for diabetes, but a real area of concern. And just finally on this point, we heard from Sharmake about Ealing Together. We successfully shielded 20,000 people during the first wave, and that's about 6% of the population. And there's an ongoing challenge, I think, in terms of learning from that work about how we continue to support people during the second wave. I'm going to move on now to talk about people living in disadvantaged areas. First of all, nationally, people who live in deprived areas have higher diagnosis rates and death rates from COVID than people who live in less deprived areas. And for us in Ealing, we've looked at this on a map, which I'm just showing you now. This is a map of cumulative infection rates, which is the total number of positive cases that we know about, analysed by ward, and it's for the period up to the 9th of November. And you can see that the sort of areas that have higher rates of infection are sort of concentrated over in the west of the borough, in Southall and Greenford areas, and also in South Acton. To some extent, this information is skewed by where we've put our local testing sites, but at the same time, we also use this information to decide where to locate the testing sites as well. So just carrying on with the key messages around deprivation. High diagnosis rates may be due to sort of close proximity to other people who are infected, and high proportions of workers in occupations more likely to be exposed. We also know nationally that mortality rates from COVID-19 in the most deprived areas were more than double the least deprived areas. So I just want to show you what that looks like for Ealing. We can see from this graph, this is not ward data, we don't have this available by ward. What we're looking at here are called middle layer super output areas. And that's a sort of geographical unit of about 8,500 people, so it's smaller than a ward. And the names across the bottom can be a bit confusing because they're sometimes not necessarily familiar to local people from the sort of wards that ward names that they know. This is data to the end of July, which is all that we have available at the moment. But the really important thing that this is showing is that there's a clear gradient across our communities, and that the if you look at the sort of the area with the lowest numbers of cases compared to the higher numbers of cases, there's a 5-fold difference across that area. So you know, there's a very clear issue for us there. Moving on then to Black, Asian and minority ethnic communities, in terms of the key messages, the pandemic has exposed and exacerbated long-standing inequalities affecting BAME groups in the UK. We know that diagnosis and death rates from COVID-19 were highest amongst people from Black, Asian and ethnic groups. For us in Ealing, we know that wards with a higher proportion of BAME residents also have higher cumulative infection rates, and members from BAME communities are more likely to be employed in sectors that increase their rate of exposure to COVID-19, and they're more likely to have underlying health conditions which increase their risk. Similar ethnic inequalities exist for the impact of the pandemic on mental health, loneliness, access to healthcare, and sort of economic impacts as well. But PHE also published a stakeholder report in June, which pointed to racism and discrimination as key issues affecting the root cause of both exposure and disease progression. And again, I think that's come out in some of the discussions we've had so far. What I'm showing you now is what we call, if you're familiar with this, is a linear regression, which is a way of looking at the strength of a relationship between two factors. In this case, what we're looking at here is the infection rate, the total infection rate to date, and the percentage of people from Black, Asian, minority ethnic communities who live in each particular ward. And what you can see here is that there is a positive correlation. When we've worked out the correlation coefficient, it comes out at 0.6, which means there's a moderate correlation, and it also means that it's statistically significant relationship between the two things. So that, you know, again, that is confirming what the national findings are. I'm showing you this, which is looking at hospital admissions as a sort of proxy for serious illness. We have to look at this with some caution, and I'll tell you why. The chart you can see is showing is showing hospital admissions by ethnicity, and the blue bars are the admissions. This is for COVID-19, obviously, and the orange bars are the admissions, and the blue bars are the estimated percentage of people in the overall population of Ealing from that particular group. So if the amount of people admitted to hospital were exactly the same as the you would hope that, you know, that if this was distributed evenly across all groups, both the bars would be the same level. And you could see two things in particular: the proportion of people of white ethnicities is significantly less than than you would expect based on the population. But the thing I really wanted to draw your attention to was the other ethnic group category, where you can see that this accounts for a much higher proportion of hospital admissions than you would expect. And what we think is going on here is that this is people who don't want to disclose their ethnicity, and that therefore they're more likely to come from Black, Asian and minority ethnic communities. And actually we think that orange bar probably distributes, should actually be put, although we don't have the data to do this, against the Asian bar, the Asian or Asian British bar, or the Black or British bar, which would clearly then demonstrate the sort of disproportionate impact on BAME communities in terms of more serious illness. So we need to do more work on this, but I'm sharing it with you because that's our working hypothesis, and it's an important point. Just two areas just to go through left. Living in an urban area, we know that, again, local authorities with the highest diagnoses of death rates were mostly in urban areas. Death rates in London from COVID-19 were more than 3 times higher than the region with the lowest death rates, which was the southwest. London, as I'm sure everyone knows, has the highest proportion of ethnic minority people, has higher levels of overcrowding, substandard housing, and highest rates of income and expenditure poverty. So in Ealing, 14% of our households are considered overcrowded. This is the 8th highest in London, who have 11% compared to England, where it's 4.5%. I think the other important thing to add here is that that standard for overcrowding is extremely out of date and wouldn't, you know, if it were to be updated, I don't think it's been updated since the 1930s, and doesn't take account of sort of, modern understanding of what overcrowding constitutes. So if that standard were updated, I think that would look even higher, and that presents a significant challenge to people in terms of self-isolating from other vulnerable members of their family, which leads on to the second point, which is that in Ealing, 25% of people over 70 live in households with working age adults. And again, we're in the top 5 boroughs in London for this sort of statistic. And again, there's important considerations in terms of how we support multi-generational households. So the last area that I'm going to highlight is about frontline staff. ONS reported that men working as security guards, taxi drivers, chauffeurs, bus and coach drivers, chefs, sales and retail assistants, and other lower skill workers in construction and processing plants had significantly higher rates of death from COVID in the first wave. Men and women working in social care also had significantly higher rates of deaths from COVID in the first wave. In Ealing, we've had a look at the proportion of people employed in low-skilled elementary occupations, and we are 11.7%, which is higher than London and England. And we are in the second phase of this work. We plan on doing some further work with our colleagues in the sort of jobs and economy area. Occupation is also related to risk of job loss, ability to work from home, and loss of income during the pandemic. So in terms of the second phase of the work, we have a cross-council steering group now who've met and considered a set of areas to prioritise for this. And I've come up with this list of priorities. So that's looking at housing, mental health, work and economic impacts on children and young people, and all of this underpinned by a sort of thriving communities approach, so engaging communities, which is probably about the most important part of this work. So, and finally, just want to finish by sharing some key recommendations or emerging recommendations on the work to date. I'm not going to go through this very busy slide. We've already heard about local enhanced contact tracing and where we're up to with that from Anna. There's loads of work going on in terms of communication and engagement, particularly working with higher risk groups and higher risk areas of the borough. We've set up local task groups in Southall, Acton, Northall and Greenford to sort of progress this work, and a consortium of voluntary and community organisations is also being formed to take this forward. So just to finish with then, the recommendations that have emerged so far are, in terms of the short-term recommendations, and by short-term we mean actions that should be considered to help us manage the wave of the pandemic that we're currently in and get us through the winter. As I say, I can't stress this enough, but the first point is about discussing the findings from the work we've done to date with our Black, Asian, minority ethnic communities, people living in our disadvantaged communities. I should also add to that sort of older people, people with long-term health conditions, just to get more insight into and understanding of the issues so that we can adapt and change and improve our responses. We've got a really strong system in place that we need to sort of maintain through the winter around protecting care homes, which is working well. We've already heard about digital exclusion, so I won't dwell on that, but that's come out as a key theme. maintaining that strong operational response with health partners, and we've heard about that already during the meeting. As you know, when we come out of the current lockdown on the 2nd of December, the newly revised tier system will come back into play, and there may be changes to which tier particular local authorities, including ourselves, are in. One of the weaknesses that we saw in the national guidance around the tier system was the advice, particularly to people with long-term health conditions. So we will review that urgently and consider what additional advice and communication we might want to put in place to keep those people safe. We are the chair talked about asymptomatic testing, so it's in relation to care homes, but we're very clear from the work that this needs to be targeted at the most appropriate occupational or geographical groups to have the highest impact. Again, important messages about vaccination rollout and how we work with partners to ensure a phased approach, which again is targeted at the most vulnerable first, and then working with our communities to understand and address the barriers to self-isolation and adherence to the guidance. There's also some emerging themes coming out that are for the longer term. So that's to inform the recovery, which includes building things like active aging into the refreshed health and wellbeing strategy that is due this year, working with older people and groups and partners across Ealing to develop the future social care vision and plans, which Kerry's already referred to, looking at the root causes of the long-term conditions and making those making sure those are built into the refreshed health and wellbeing strategy, and then working with partners to strengthen prevention and effective management of long-term conditions. Thank you very much for your attention. I'm very happy to take questions. Thank you, Chair.
Thank you very much, Wendy. That was a very, very full and informative presentation. So thank you for that. I'm mindful of time, but does anybody have any questions that they want to ask? Obviously, we'll look to see if we can share those slides with people as well. I can't see anybody coming forward, so let's thank you, Wendy. Let's go on to your presentation, Anna, about where we're at with COVID cases.
Yeah, thank you, Chair. Can you see that okay?
It's just coming up. Yeah, we can see it now.
Great, thank you. I'll keep my video off because my signal's not great, apologies. So I'm just going to go through really briefly the current situation of COVID nationally and in Ealing, some of the work that we're doing across the council in terms of communications and community engagement, the new contact tracing service I've already mentioned, and then really briefly just touching on some new developments, especially around asymptomatic testing and vaccinations. So nationally, those graphs at the bottom are probably worth focusing attention on. So it's really important to say that in Ealing, we are kind of following the national trends generally, where we have seen a very sharp increase in cases and the number of people that are testing positive for COVID in the last couple of months. We are seeing that number decrease in the last week or so nationally, but in London, we are seeing the numbers still staying quite high. Importantly, we are starting to see the number of people dying with COVID and the number of people admitted to hospital have increased over the last couple of weeks, and we are seeing that across London as well, although not particularly high numbers at the moment, but we are seeing those increase. Just to mention nationally, we are in the current national lockdown restrictions up until 2nd of December. We are going to move back into a new set of tiers being published this week. On Thursday this week, we'll find out which tier London will be in, but they are likely to contain stricter measures across regions. So we will find out more later this week. In terms of Ealing, this graph shows the number of people who were testing positive for COVID. So Ealing is the green line. We did see a very sharp increase across October and early November. It's fluctuating now, but remaining at a high level. We are going to see in the next week if there's been an impact from the lockdown restrictions. That's just going to start coming through in the next few days. We are higher than North West London and London, but at the moment lower than England. In terms of people who've unfortunately died with COVID, we have had a further 8 deaths in the week with the most recent information, so up until the 6th of November. And so the total number of deaths has risen to 437. That rate is very similar to other areas in England. And we will obviously that's a concern, and we need to see if there are any changes or any increases in that rate over the next few weeks. Just briefly in terms of outbreaks, so this is where in schools, for example, it's where we've got 2 or more people testing positive where we can say that they're linked. We are seeing 3 schools at the moment with outbreaks. 2 university settings, 3 workplaces, and then importantly care homes. We are seeing 19 with confirmed outbreaks, and about 5 of those are either partially or fully closed. I think importantly for schools, it's worth mentioning that state funded students, we are seeing about 2,600 at the moment are being educated at home because either they've tested positive themselves or either a household member or someone in their class has. So that's obviously having a big impact on people's day-to-day lives. And I know the schools are working really hard to minimise that impact. And then just moving on to some of the work areas. So there's an awful lot of work going on around communications to distill key messages around prevention, isolation, test and trace, and also around the support that's available for residents. Some of that work is universal, so for all residents. So for example, letters and the magazine that's sent to all residents. And GP practices are working with us to send out text messages as well. But some of the communication is targeted, and I think that comes back to some of the inequalities aspects that Wendy was talking about. So we have got our digivans, which are essentially vans with TV screens on the side. So we are deploying those with the clear communications messages in some of our higher need areas. Using social media in a targeted way, and I think really importantly trying to translate material into different community languages where that would be helpful. We're also doing a lot of work around community engagement, and that's something that's really building up over time and something that we want to enhance. I think it's really important that we share that understanding of how local communities view the key COVID messages, and importantly the barriers that they're experiencing. So why might people not want to get tested? Why might they choose not to self-isolate or for example to wear masks? So we've done a number of meetings in some of our higher need areas that we're calling task groups. We've had I think 4 now. So that really involves a real mix of community leaders and representatives from across faith settings, voluntary groups, residents groups, schools, NHS colleagues and council officers. And they're really, really useful forums for us to have discussions around how messages are being heard and understood and what barriers people are starting to experience. We have awarded a voluntary sector grant to a provider called Each, who are currently recruiting a consortium of voluntary and community sector groups. And that consortium's work will really focus on communities at a grassroots level that are most affected by health inequalities and deliver training and support by those organisations. So that's something that's only just starting now, and hopefully by the next meeting we can bring back an update on that work. Contact tracing I mentioned earlier under the questions. So that only launched about a week and a half ago. It's a small service that's running well, and once that's up and running fully, we can report back on progress and our next steps with that service. And then I did want to touch briefly on testing. So we currently do, there's testing available if people have symptoms. So they can either get home testing kits or go to one of our local testing sites in Acton, in Southall, or at Gurnell Leisure Centre. What is available now nationally is the government has approved use of some rapid testing kits. So these are almost look like pregnancy test kits, where you do a swab at the back of your mouth or in your nose, and you wait for 15 to 30 minutes and get a result. We are able to access up to 10,000 tests in Ealing from the central government's allocation, and we're really working on at the moment very quickly trying to take a phased approach to rolling this out for people that don't have symptoms. But where finding positive cases would be really helpful to protect vulnerable people, or to help people go about their days and their lives as much as normal as possible. So we're taking that phased approach so that we can build up local capacity and develop our systems, and really importantly to benefit from the learning that's coming out of a number of pilots across the country. We are going to focus so far on adult social care settings to really reduce their impact on vulnerable residents, but we are working across different boroughs in London to really learn from each other and to think where else we can roll this out. As our chair announced earlier, we have got national plans coming out around testing for care home visitors and for people who go in and help in people's homes. And so we're really keen to push forward with those and support our local organisations where we can. And similarly with universities especially, they're being covered through different routes in terms of testing, but again we're happy to provide support. And then I think people will have seen a lot of media coverage of places like Liverpool where they are doing this kind of whole community testing. It's something that we are waiting for national announcements on that, and really importantly waiting for the learning to be shared so that local areas can make decisions on where that may be useful in the future. And then just finally, I mentioned that the NHS is leading on preparing for COVID vaccinations. They're preparing for that to be in place by early December, so that hopefully as and when any vaccinations are approved, we will be ready to go, hopefully towards the end of this year or into next year. And we are, I think, a really important piece of work in the council for us will be around communications and community engagement. I think obviously it's a new vaccine, people will have concerns about it, and it will be, hopefully into next year will be a really big rollout across the adult population, and it's something we're really keen to work with communities to support them through that process. Those initial priority groups are people aged over 80 and health and care staff, but hopefully over the coming months that will expand into younger age adults. So Chair, that was all I wanted to cover today. I'm very happy to take any questions.
Thank you very much, Anna. Anybody got any questions? Again, an awful lot of information, which was really helpful.
Chair, can I just make one comment around hospital admissions?
Yeah, of course. Go ahead.
So Anna referred to increasing admissions. What I would say is they have stabilised. So if we go back to the 30th of October at Ealing, we had 44. The following week on the 5th, we had 40. Last week we had 60. Today we're at 52. Sorry. So we peaked at around about 60 inpatient admissions for COVID. We're at 52 today, and it's been at 52. The late 40s, early 50s for about a week now. So hopefully we've reached close to the peak. I can't say it's definitely peaked, but it seems to be stabilising over the last few days. And
I'll leave it at that for now.
Thank you. That's really helpful. If nobody's got any questions, let's move on. I am mindful of time. We've got our 2 Health Watch items, 10 and 11. So the SCAN one first. Who's going to present that for us?
Yes, that's me, Chair. Matt Van.
Hi. Yeah, hi Matt. Go ahead.
Hello, thank you very much. So if I'm just able to share my screen with you all, I'll try and be as succinct as possible.
Yeah, brevity is the order of the day.
Okay, fantastic. So we've got 3 reports to actually present, and I wanted to start with the patient experience report, if that's okay, just because it dates back to Q1, and we're now able to compare this to our Q2 results, which is quite useful. Then we'll follow on with the SCAN report, and then finish off with the COVID-19 report that we conducted back. I'll try to answer as many of the questions I can as possible, but I did pick these reports up at a late stage. So if I can't answer them, I'll take them back to the team and see who can. An experience report dating from April to June. And this is very much the eye of the COVID storm. So we had to rearrange how we were gathering patient feedback, and as a result, rearrange how we looked at our data. We were able to achieve our total target of 300 reviews, which was significantly reduced from the usual target. And as we can see here, overall, there was a positive sentiment from the reviews we got. And the negativity was largely focused, unsurprisingly, on administrative issues at GP surgeries, particularly around booking and availability. It should be noted that we had to include a number of caveats in this report, as some of you may have seen, because a lot of the service categories that we were gathering feedback on didn't receive the appropriate amount of feedback in order to draw any firm conclusions. So as you can just see at the bottom of the slide here, anything under 10, we would recommend to the reader that they bear this in mind and understand that these aren't necessarily representative of the total population. From this report, we were able to understand how we could further develop as an organisation to gather feedback, and we obviously didn't gain too much clarity around what was happening within the borough with patients, aside from these issues with administration. We were able to pick out some areas and actions and recommendations that we could make to ourselves internally for the team, and understand how we could better gather reviews in the following quarter. So as you can see here, for point number 3, we were really trying to focus on how the COVID-19 pandemic has impacted residents. And number 4, start to think about how we can conduct annual reviews as well, to understand how this has changed over time. So the real point I wanted to touch on here comes from Q2, where we start to see our numbers more like they are in previous pre-COVID quarters. And this is where we started to gather more reviews. So as you can see, we've increased from 306 to 1,000 reviews collected, and the positive sentiment still remains largely the same. Speaking to the volunteers that do gather information, a lot of them said that one of the key things they were seeing was a great deal of understanding from Ealing residents, particularly around these issues of administration, booking, treatment and care, and the pressures that healthcare professionals are under. We started to gain a lot more reviews from people who had experienced time in hospitals, and pharmacies, opticians and dentists, which were quite low in Q1. The sentiment was largely positive for hospitals, pharmacies, opticians and dentists, and something that we're currently looking into at the moment is how we can further support GP surgeries that may require improvements around the administrative side of things and experience of treatment. But this Q2 report isn't quite ready yet, so this was just a kind of brief comparison to Q1, just to show you how we've improved over the 2 quarters. We then move on to the eScan report. Now this was looking at the services at Carmelita House for children with additional needs. And again, this was a report that was conducted right at the start of the pandemic. So this did impact our data collection process. We were able to collect feedback from 64 parents and or carers of children who use the services at Carmelita House. And this was really, the aim was to really understand how we could further develop the services, but also how we could take best practice from Carmelita House and apply it to other services throughout the borough. What we found was that the majority of the feedback was positive around the quality and delivery of services. Parents and carers made a point of noting that the quality of treatment did contribute to the overall development of their children, which was really nice to see. And a particular point that parents and carers pointed out was staff attitudes and behaviours, both when communicating with them and communicating with the children, instilled a great deal of trust that their children were in a safe environment. Unsurprisingly, there were some highlighted issues around waiting times and some key points that may need to be available for children with certain disabilities. And on top of that, another area of development that parents and carers pointed out was one of communication for regular updates on services, just to make sure that they were on the same page. And this can be seen in the recommendations here. So we have some practical ones. For instance, in the bottom left here, a mobile hoist to lift physically challenged children. That was one recommendation that came out of an interview with a particular parent or carer. And then some more overarching recommendations, such as in the middle on the right, leaflets and emails providing service updates. And this is really to ensure that people are on the same page about the care that they're receiving. We're still awaiting the response, and the lines of communication remain open with Chris Hilton, but we understand that there's priorities at the moment, so we're keeping that line of communication open for the time being, and we'll just update the report whenever we do receive the response. Finally, we move on to our COVID-19 impact survey. And this very much follows on from Shamake, Wendy and Roy's presentations and questions. So this is a particularly useful meeting to bring it up in. We were able to receive feedback from 467 residents during the space of the month between May and June. And we really focused on 4 key areas. So this was who is at high risk, access to care, access to information, and mental health and well-being. We'll come on to the first one, who is at high risk, towards the end, because this is really where we like to focus our recommendations on. And we start with the access to care. On the whole, changes to healthcare appeared to meet the needs of the patients. What we saw was a lot of cancellations, but at the same time, a lot of adjustments like we see at the bottom, with between 23 and 27% of participants indicating that they had received some sort of support in replace for GP appointments or hospital appointments. And 60% of individuals rated the communication about these changes as good or excellent. So the majority rated the communication as good, but obviously there's still some communication that needs to be worked on and improved, and that's something that we'll come on to in the recommendations. While the uptake of digital services is clear from this report, hopefully you've all seen the question that I'm referring to, the actual experiences and what people reported has been fairly mixed. These issues particularly cropped up around using repeat prescription systems, GP appointments online when a phone call would have sufficed. And so these are issues that need to be looked at in more detail, and follows on from Shamake's point in his previous report. There's also an indication and a running theme throughout this survey that people heavily relied on friends and family, and we'll come to a point later on about access to information where this could be a potentially troublesome situation where people trust the information they're receiving from friends and family rather than authorities, particularly around interacting with people who are shielding and things like that. Next is the access to information section. In access to general information. However, when it came to specific topics, such as managing long-term conditions, shielding guidance, and where to get COVID testing, people weren't as clear on these issues. So while they understood the general message, when they actually needed information on a specific topic, they weren't as confident that they could, or that they had found this kind of information. Interestingly, a smaller percentage of people found that it was easy to actually act on the information that they had received. So while the uptake was the majority, we started to see a decrease in people who were actually able to act on it. And this could be related to not getting the right communication through on these specific topics. So that is something to look at in further detail. Overall, one positive is that individuals are using a wide range of channels, and that this could be something we work with the communications teams to highlight what channels specifically target certain groups, such as using social media for younger groups, newspaper, radio for the older age range in the borough. Mental health and well-being. Unsurprisingly, there was a big impact on the residents that completed our survey. 78% indicated that they had been impacted in some sort of way in their mental health and well-being during the pandemic. Highlighted was the inability to access testing, particularly at the start of the pandemic. This was a stress for many people. And again, individuals are more likely to turn to friends and family for mental health support. While this is obviously natural, the lack of information that we see on specific topics, as previously mentioned in the access to information, does pose quite a worrying question, that are these people getting the right information regarding their mental health and regarding these specific topics, and do professional services need to do more to make sure that their communication is being heard. There is some indication that there's a lack of awareness around the mental health services that are available, and this obviously may contribute to this reliance on friends and family. And then finally, we move on to this health inequalities section, which is really looking at who is at high risk. We found that individuals from BAME communities were more likely to be advised to observe shielding guidance by the NHS compared to people of white ethnicity. They were also more likely to be unpaid or informal carers for somebody who was shielding or considered to be at high risk. And when comparing the impact of COVID on mental health and well-being, BAME respondents indicated that the pandemic had significantly impacted their mental health and well-being far more than those of the responses of white respondents. And these are three. Although this report wasn't focused on trying to find health inequalities, these are three that we were able to pick out. And as a result, this forms a large part of our recommendations, which I'll come on to now. So first and foremost, these are the 3 recommendations that are a lot more general. Clear lines of communication with a targeted approach is important because, as we mentioned, these specific topics aren't getting to the right people in a lot of instances. And there could be work done on how we get the right message to the right communities, whether this is housebound individuals, people of a certain ethnicity or a certain age group. There needs to be work done, we feel, to take a much more targeted approach to these lines of communication. Something else that was highlighted was that a focus must remain on telephone consultations for people that aren't as digitally competent as others. It's all well and good to have these services up and running, but if people don't know how to use it, then often the best bet is to call, or obviously in emergency circumstances, actually bring them into the GP surgery. And something that we will do is work with community sectors as well as alongside the CCGs to ensure that the right digital services are promoted, but also what more can we do around that, whether that's distributing physical copies of information and appropriate numbers, translating this information into the right languages, and things like that. So we can definitely work with partners to understand how we can better disseminate information. And then we move on to the recommendations for the mental health support. We suggest that mental health services should remain a priority for support, particularly as this second wave has hit. The impact that mental health and wellbeing has taken from the pandemic, and we would be a partner in this, and we would support mental health services as much as we can. And this is a conversation that we can obviously take offline. And we would urge these organisations, as well as primary care, to reach out as much as possible to people that they feel are socially isolated, or support any befriending services for those communities that are marginalised. Our final recommendation is around the inequalities that we see in the report and that we see in Shamake's report and other reports on the health inequalities. We've started conversations with GOSAD and BAME-led organisations that they have previously worked with to try and understand and identify these themes and how we can transform recommendations into actions, mapping out short, medium and long-term priorities. From the discussion that Healthwatch had with GOSAD, we identified the 4 key issues that were actually brought up today. So the digital exclusion, social isolation, a lack of access to information in some circumstances, and just an overall sense of feeling forgotten by authorities. And these are the four key issues that we would like to address. And we would urge Ealing, CCG and LA partners to be a part of these efforts. Healthwatch will continue to do its work and try and implement innovative ways of gathering feedback from these communities, such as translating surveys into the appropriate languages and gathering feedback, and gathering feedback from these communities. And we'll aim to further build relationships with these marginalised communities through our community engagement work. What I'd like to ask of everybody in the meeting today is that we would like to spearhead a working group with the CCG, LA partners, GOSAD and others. And this would be an inequalities working group with the aim of really understanding all the feedback that we've been able to get from certain reports and findings, and formulate a series of jointly agreed recommendations that we could take forward to understand what we are addressing in the short term and what we were studying in the long term. Healthwatch have 2 things. We have very eager volunteers who specifically want to address these issues in any way that they can help. And we also have the capacity to take on more volunteers. And whether it's an issue of support or financial support or just collaboration, we would like to be spearheading this Inequalities working group and do as much as we can to work, try and implement some of these actions and recommendations that we're seeing throughout the reports that we've discussed today. And those are the 3 reports.
Thank you, Matt. I'm mindful of time, but are there any questions that anybody's got? Or comments? And I know we've still got our winter plan to do. Yeah, go on, Naini.
Just to say that I would welcome taking up the offer with Health Watch to do the work, so count the CCG into that piece of work.
Fantastic.
Yeah, and obviously there's an awful lot of work going on around this. Obviously, the work that Wendy is doing on behalf of public health, and we've also got our Race Equality Commission that's got an independent chair, which hopefully we'll be announcing very shortly before the end of the week who that will be. So that's exciting. But I'm sure, yeah, we need to pool our resources and make sure that we capture the really critical messages. Thank you, Matt. I think, Kerry, you're going to do the winter plan.
Thank you, Chair. As in the documentation, the Department of Health and Social Care wrote to all directors of adult social care asking us to confirm our winter planning arrangements. The Council's worked in partnership with the CCG and other NHS partners to ensure that we have a cross-cutting view of our winter planning and preparation. This report provides confirmation of the planning in line with the framework that was shared by DHSC and is for information and to take questions, really, Chair. There are a number of outstanding actions, but a number of these have progressed already, such as DAS representation on the DPH COVID surveillance group, which I now attend, and also work with providers with regards to best practice and learning reviews. So it's really opening it up for any questions, Chair, if that's okay.
Yeah, thank you, Kerry. Yeah, who wants to ask a question? I've got a comment in the chat thanking Matt for his SCAN report from Chris. Any questions on the winter plan?
Yeah, I might comment just to say that it was discussed today at the Ealing, the London North West A&E Delivery Board, as was Brent and Harrow's, and to say that we were included as part of the discussions, and the local authority winter plans, the Trust's winter plan, and the CCG winter plan were all joined up this year in terms of shaping up to how we would respond to winter and take account of potential COVID. So happy to say that it this year it really did feel like a joined up process, and as I said, that was discussed today and supported at the A&E Delivery Board.
Thank you, Sam. Fine.
Julian, Shamaki, quickly.
Yeah, go on, Shamaki.
Yeah, so I raised my hand earlier on when Matt gave that presentation. Yeah, I just want to say something. Looking at the SCAN plan and SCAN report, and just all the presentation we had so far, with Wendy and Anna, which I think are amazing. But there's one thing that, as somebody who also wears different hats and provides advocacy work within GOSAD, there's an issue around advocating for. So, for example, if you look at the SCAN report, I think there's 8% of respondents who had negative comments. Now, I think is one thing to collect that kind of information, but it's another thing to, to follow up, because we know there's a lot of people who have got misgivings or things have gone wrong, but unfortunately, there's no support to advocate for them. And we see a lot of reports, we see a lot of recommendations, but I think advocating for those people, for example, come through the door of a lot of civil society organizations is something that we know it takes time. It turns into a caseload sometimes. And of course, it's resource heavy, but it's something that has to be done, because just by trying to adapt some kind of recommendations, sometimes it kind of misses those people who maybe have been let down by maybe a certain service. So I just wanted to put that as a comment that, it's a huge area that we need to kind of consider. And also, it's weighing down on a lot of voluntary organizations to advocate for people who have got misgivings or things have gone wrong. Thank you.
Thank you, Shamaka. My apologies for not seeing your hand. Okay, I think I can't see anybody else's hand up or any comments in the chat. So we've dealt with the single CCG item. So our final item is the work programme. We've talked about putting on at an appropriate moment the integrated care system, and we will continue to get updates on COVID and vaccinations and asymptomatic testing and all of those kind of things. And I don't think we need to spend any more time on that, unless there's something that somebody wants to absolutely put on the forward plan that I've not mentioned.
Chair, it's Anna here. I think it's just that we will be bringing back to the next meeting the next phase of the integrated impact assessment. So the next phase is really to talk to communities and also to look much more widely on the kind of more of the economic and educational impact of COVID and some more recommendations. So if you're happy, that would be great to bring to the next meeting.
Yeah, no, absolutely. So fine, let's add that as well. Fine. My apologies. My poor chairing has meant that we're 24 minutes past the point where I normally call a halt to proceedings 2 hours in. If this was a private Zoom session, we would have and we weren't subscribing, we would have gone after 40 minutes, but we would have missed an awful lot of vital information that has been really enlightening and helpful tonight. So a big thank you to everybody for contributing. We don't have another meeting until after the Christmas and New Year break, so we're next meeting on the 26th of January. Let's hope that we have some kind of break over the festive period, and there are all kinds of new rules to get our heads around as to whether we can have bubbles with 3 households and so many days where that can happen, and travel where we want, but it's the season to be jolly careful, I think, to quote the Prime Minister. So thanks, everybody.
Thank you.
Thank you.